I'm going to talk about critical appraisal of the educational literature as part of the Educational Scholarship series. Just trying to advance my screen here. There we go. So I'm the first presenter today. My name is Aine Marie Kelly. I'm a professor in radiology, Division of Cardiothoracic Imaging at the University of Michigan. I'm a clinical radiologist, clinical educator, board certified physician, and I have a master's degree in clinical research design and statistical analysis, and I have a master's degree in higher education with a focus on medical student education. I have a couple of disclosures. One is that I am one of the co-recipients of the AUR Research and Education Venture Fund grant in 2017, and I thank the AUR Research and Education Fund for that. I'm also editor of one of the Springer books on evidence-based emergency medicine, which will be mentioned twice during this presentation when I talk about evidence levels. The format for this presentation is didactic and interactive, and we welcome questions at any point during the presentation. Some of the things we talk about will be our personal experiences, and I'm going to talk about the learning objectives now. These include learning the benefits of critical appraisal of the educational literature, becoming familiar with the steps involved in the critical appraisal process, learning how to evaluate study types, levels of evidence, and assessing for validity, quality, bias, and statistical strength of the retrieved studies. We'll also outline broad categories of educational research projects, and time permitting, we will look at some critical appraisal skills as they apply to your educational research efforts. I will also be covering this in a future webinar on the 25th of June. So the first thing is to define what we mean by critical appraisal. This is using explicit and transparent methods to systematically examine research to assess how trustworthy it is, its value, and its relevance. Critical appraisal is the third step in the evidence-based medicine process. The first step being to ask an answerable question, the second to search the literature, the third to appraise the evidence retrieved. The fourth is to take action upon the findings and apply them to your population of students. And the fifth step is to evaluate the impact. So why should we critically appraise? For one thing, there's a regulatory requirement to keep up to date and be involved in lifelong learning. That is the stick. And then there are some advantages, which include evidence-based practice. Critical appraisal underscores evidence-based radiology. It helps you build a very strong foundation for your research studies. It helps you become a stronger reviewer, and here I'd like to make a plug or a plea for more reviewers of educational articles for academic radiology. So the first step is to formulate the educational research question. This is the foundation or the basis for the critical appraisal process, so it's a crucial step. Questions typically have 3 or 4 parts and are abbreviated to PICO. P is your specific patient or population or learner group. I is the intervention, which is an educational intervention in educational studies. C is the comparison group and their educational exposure, and O is the outcome of interest that we're looking at. So we did a study at the University of Michigan a few years ago in which we did a pre-clinical radiology elective for medical students. We incorporated the ACR appropriateness criteria, and we wanted to evaluate the impact of that. So putting this into the PICO format, this would be phrased as, in preclinical medical students, that's our population, did the incorporation of the ACR appropriateness criteria into radiology elective teaching, that's the intervention, make them more appropriate users of diagnostic imaging, that's the outcome, compared to medical students who didn't do the radiology elective, that's the comparison group. The next step in the evidence-based medicine process is searching for educational literature. You can find information from discussions with colleagues. consulting textbooks, or journal articles. But you can do a more focused search by looking up computer databases, such as PubMed, Medline, or for educational articles, the Education Resources Information Centre and the Cochrane collaboration. And librarians or informationalists are great resources to help you in your search efforts. So critical appraisal involves various steps, and we're going to start in the next few seconds looking at determining the study level within what we call the 4S evidence pyramid. After that, we'll look at study evidence levels according to the Centre for Evidence-Based Medicine. And then within the study, we will look at the methods section for validity, evaluate for bias, and also look at the statistical strengths in the results section. So literature has been ranked by scientific methods, and it has been assigned to various levels. Brian Haynes and colleagues from the Oxford Centre for Evidence-Based Medicine described an evidence pyramid in which at the base of the pyramid are the original scientific articles, original research studies, and these comprise most studies that you will retrieve in your literature search. Above this, in level 2, 3 and 4, are syntheses, synopses and systems. These are known as secondary studies. Syntheses include things like meta-analysis and systematic reviews. Synopses are the next level up, and these are short summaries of published research produced by experts. At the top of the pyramid are computerized decision support systems, which link individual patient information to the latest evidence and guidelines. The evidence pyramid, a few years after it was brought out, was expanded to become 5S, in which they added a fourth level between the top level, the systems, and the synopses. And these were summaries, and these were more elaborate guidelines, often drawing from the lower 3 levels of the pyramid, but with a focus on meta-analyses. And these include evidence-based textbooks and journals. This slide is a busy slide, but it just shows some examples of sources of evidence resources, such as synopses and summaries, like the American College of Physicians Journal Club or the British Medical Journal Best Practices, syntheses, such as the Cochrane reviews, and original studies, which are often found on PubLine or Medline. So going to level 1, this is primary evidence from original scientific research, and this is found on computer databases such as PubMed, Medline, ERIC or Google Scholar. This comprises the majority of studies, and particularly within radiology and radiology education, most of the studies will come from this layer of the pyramid. PubMed can be searched using a single term, and it's a free resource as well, or it can be used with a combination of terms using the Boolean operators and or or. ERIC is the Educational Resource Information Centre and is also a free search engine for educational articles. Google Scholar is another free search engine. And then level 2 is the first layer of the secondary evidence. And from here up, all of this evidence has been pre-appraised by experts. Electronic databases where you'll find this includes the Cochrane Library, the Turning Research into Practice or TRIP database, the National Institute for Clinical Effectiveness in the UK, the Scottish Intercollegiate Guidelines Network, PubMed and SumSearch2 from the University of Kansas. This is the Cochrane Library, and it's another free resource. TRIP is also free, though you can upgrade to a more advanced version for a subscription. The National Institute for Clinical Excellence is free, as is SIGN. The SumSearch2 search engine is also a free resource. PubMed has the Clinical Queries tab, in which you can input medical education subject heading terms using the Boolean operators and or to perform searches, and is also free. Moving up, level 3, the synopses, is secondary evidence, and these are short summaries derived from experts who look at the current best evidence and give guidelines, often for a specific scenario or situation. From here up in the evidence pyramid, these sites usually require a subscription to access. And examples of synopses include the American College of Physicians Journal Club and Evidence-Based Medicine Online. Moving up to the summaries level, these include textbooks in print form or online, which provide best evidence derived from the literature with an emphasis on systematic reviews, and they provide more comprehensive guidelines and discussions to help people in practice. Examples include the British Medical Journal Best Practices, Up to Date, and the Evidence-Based Imaging book series. These are a couple of examples from their websites, and this is the Evidence-Based Imaging book series. At the apex of the pyramid are level 5, which is the information systems, and these are systems that link the latest guidelines and evidence to individual patient level, and these include clinical decision support systems at the point of order entry. These are being integrated nationwide, and these are a couple of examples which were mandated by the Centre for Medicaid Services. So I just want to pause for a moment and try and dispel any confusion that I'm about to create, because up to now I've been talking about levels with regard to the evidence pyramid. I'm about to talk about more levels which are slightly different. These are the Oxford Centre for Evidence-Based Medicine levels. And I'm just going to skip forward, forgive me for a moment. I want to show you the evidence pyramid, and you'll recognize what we've been talking about. But the Oxford-based Centre for Evidence-Based Medicine has an evidence hierarchy which focuses on the original studies and also on systematic review. So it focuses on level 1 and level 2 of the evidence pyramid, and it's a hierarchy of ranking of studies. And these are the studies found in journals and are largely non-pre-appraised studies. So jumping back, I've simplified the table a little bit, and what I want to show you is it extends from level 1 at the top of the hierarchy, which would include systematic reviews of randomized controlled trials and randomized controlled trials, through level 2, which would be cohort studies, level 3, which would include case control studies, level 4, which would include case series, and level 5, which would be anecdotal reports, descriptive studies, or consensus expert committee reports. So these are another level, not to be confused with the levels in the 4S or 5S pyramid. So retrieved studies need to be evaluated by looking at the methods and the results section in particular. Validity is determined by asking, is this an original study? Have they done it before? Are they doing it differently? How are they advancing the science? We also ask, was there an independent comparison with the established curriculum or teaching method? We should also ask, was the intervention evaluated in a real-world setting, an appropriate spectrum or situation? And it's always good if the education intervention was validated in a second or independent group of learners. Bias should be looked for too. It's important to ask, how were the learners selected? Could there have been recruitment bias? The inclusion and exclusion criteria need to be explicit. Learners should have been evaluated in real-life circumstances so that you could do this in your own home institution. It's important that researchers state explicitly what they did. This is so that you could take the study and reproduce that in your own home classroom. The outcome measured needs to be justified why it was selected and explicitly stated. It's important that they take steps to avoid or minimize bias, and as well to have independent assessment. I just wanted to mention briefly, sample size is always a challenge in educational research, And in general, studies with sample sizes less than 30 participants should probably be labelled as a pilot study or a validation study. Evaluation for statistical strength involves looking at the results, and I often look for statistics, pardon me, but I just want to mention that in qualitative studies, it's often not necessary. So in education, they don't always have to have a statistical analysis, particularly if it's descriptive. The data can be analysed to see is it numeric, ranked, dichotomous, or categorical. One should look at the population as well to see is it a normal distribution or non-normal, and that will sometimes involve graphing the data to see does it have that bell curve configuration. I also check how many groups there are, is the data dependent or independent. Sample size will impact the power of the study to show a difference. Statistical significance is often done using p-values, though effect sizes are becoming more popular and are independent of overall study size. Precision measures should also be incorporated, such as confidence intervals. If you're uncertain about statistical aspects, I would advise seeking a biostatistician at your own institution, or most journals that you review for also have biostatisticians connected with them who are very keen to assist. This is a busy table. I'm not going to go through it, but it's just to show that for certain populations and certain variables there are specific tests that should be used, and this is part of the appraisal of articles that we retrieve. So authors have looked at education research studies that were successful or unsuccessful, and this slide shows the areas in which strong studies excelled. This included having an important, timely, relevant, critical problem. These studies were well written, logical, and easy to understand. They were well designed and executed with appropriate methodology. They were founded on a good review of the literature, a well-articulated problem statement. The implications from the study were practical, sample sizes were adequate, and they accounted for study limitations whenever possible. On the other hand, studies that were weak or rejected by journals was often due to inappropriate or lacking statistics when there should have been, overinterpretation of results or over-testing, an inappropriate instrument to measure the outcome, a small or insufficient sample or a biased sample, text that was difficult to follow or understand, and often an insufficient or incomplete problem statement. So the last couple of steps in the evidence-based process are to apply the findings to your population or class group and evaluate the performance. So it's taking the results from published studies and applying them to your classroom. And this is translating the effectiveness to the efficacy. And with any new methodology or initiatives, there's going to be a learning curve, and it might involve multiple iterations to optimize things. I'm going to change gears a little bit and look at education research study types and outcomes, just to put things in context. So educational research falls into many areas, and you'll see it's quite encompassing. This includes things like learner and teacher performance and assessment, satisfaction, learners and teachers, new teaching methodologies, describing them and the effects of them, curriculum design, implementation and evaluation, as well as program evaluation, technology and radiology education, professionalism aspects, and costs. Authors have looked at education research subjects and found that they mainly focused on trainee satisfaction, less often on faculty, providers, or patients. Similarly, when they looked at the outcomes, it was mainly based on performance and satisfaction, less often on professionalism and cost. Educational research studies can be divided into broad categories. These include consensus conference proceedings, which are reports of expert committees using a Delphi process and tracking of attendees and noting down their preferences. These also research studies include primary studies, which are the scientific studies. They're first-hand or level 1 of the level evidence pyramid. These include terminologies that are slightly different to non-educational projects. They have experiments, surveys, and mixed methods research. Secondary studies include overviews and systematic reviews and meta-analyses, guidelines, and decision and economic analyses. This is an example of a consensus proceeding in a radiology publication. It's on radiology education from a few years ago. I just wanted to mention unique to educational research are curricular innovations, and there's a very well-established process which is the Currin cycle, and this is the book Currin Curriculum Development for Medical Education. But it involves these steps. For example, if we have an issue such as we don't have a cardiac resident lecture series, this is our problem. We could assess the learners who would say, yes, we need this for the board examinations. We would then establish what are the educational goals and objectives to pass the exam and to practice independently. We would then design instructional strategies, which might include case-based studies incorporating evidence or workshops. Implementation would involve practical aspects such as who is going to deliver it and how the program will be laid out. And then after delivery of the intervention, the residents will be evaluated and feedback to the organizing faculty, and the process could be repeated to try and tweak it and make it better. Continuing to look at educational research outcomes, these are many and include performance and assessment, which can be student, patient, teacher, provider, satisfaction, opinions, feelings, beliefs, and attitudes. And these can be assessed using numerical scores, ranks, Likert scales, or free-form comments. Quality of life, such as patients' activity of daily living, could be assessed after an educational intervention or counselling. Professional aspects include career choices, promotion. And other outcomes would include more objective things such as exam scores, teaching settings, teaching techniques, whether that be descriptions of the implementation, the desires of the learners, or the perceptions from the learners, exam settings and tools, and also satisfaction and opinion. And this could be about anything such as the on-call schedule, shift systems, feedback process, quality of feedback, teaching formats and styles, or changes needed to improve conference attendance. So quantitative education research, like other areas of research, involves objective measurements such as numerical scales. They often have larger sample sizes and have an underlying hypothesis. I just want to say that qualitative studies often have a hypothesis as well. Quantitative studies use statistical methods to compare, rank, assess trends, determine causality and relationships. Qualitative studies, on the other hand, often have a Likert scale or free comments, such as the speaker's accent was a joy to listen to during this educational seminar, or one change I will make to my activities after listening to this webinar is, for example. So we're going to turn to the study designs in education, and I'm going to show you some flow charts. Studies can be descriptive, such as a new method like a flipped classroom, or they could be correlational, such as looking at residents who are medical students who are exposed to radiology electives and their likelihood of going into radiology, cross-section studies such as surveys, and finally analytical studies or experiments. Experiments are classified using terminology that's different to non-educational research, and this includes experimental studies, equivalent to randomized controlled trials and prospective trials, quasi-experimental, equivalent to cohort studies, and pre-experimental, which is equivalent to case-controlled studies. I'm going to show you some flow charts of these. So experimental studies include the randomized controlled trial, comparison group, and a unique study in education, which is the Solomon 4-group design. So in the randomized controlled experiment, the class will be divided into two, randomized. I have to say in practice this is very difficult to do. This is more theoretical. The class will be exposed to an intervention, or at least half of them would, and then they will be tested afterwards. A more realistic one is the comparison group experiment, in which the class is divided and matched as much as possible so that they're comparable. Half of them get the intervention and they are tested after that. Another design would be to incorporate a pre-test before doing the intervention and the control to evaluate for changes between the pre and the post-test in the intervention group. Similarly, this is the controlled experiment. Sometimes students or learners will perform better on the post-test because they've taken the pre-test. So the Solomon 4-group design was designed to account for the effect of testing on their performance. So they would randomize or divide the group into two groups, half of whom would do the pre-test, half of whom wouldn't, and they would undergo the intervention or the control and the post-test after. And this helps to kind of flush out the effects of pre-testing on the post-test performance. Moving on to quasi-experimental study designs. These include the non-equivalent control group, counterbalanced, and time series, and I'll show you some flow charts of these. The non-equivalent control group post-test is shown here, and in this situation a class is divided. There's less ability to control for variables that might affect the outcome. Some of them undergo the intervention and then there's a post-test after that. The non-equivalent control group pre and post-test is similar, except that the students undergo pre-test before they undergo the control or intervention. A counterbalanced pre and post-test design is similar to studies in drug trials where people take two medications but at a different time. So in the educational setting, the class would undergo pre-test to assess the baseline. They would have the educational interventions, they would have testing, and then they would reverse the educational interventions, and then they would retest. And then a time series is a study fairly unique to education, in which a class, such as a resident group going on call, would undergo pre-test to assess their knowledge and readiness for on-call. Interventions would be repeated and would include lectures or workshops or practicums, and they would be tested after these to, assess their readiness for call or knowledge. Pre-experimental designs include the one-group post-test only. It's also known as a one-shot case study design. The one-group pre- and post-test, and the static group comparison design. This is also known as the separate sample post-test. The one-group post-test only is a group of students who undergo an intervention and have a post-test. There is no comparison group. The one-group pre-test post-test is similar, except that we add in a pre-test before they have the educational intervention. And then the static group comparison design is one that we will see a lot in practice, where the two groups are different. They may be two groups within a medical school or a residency program, or they could be in separate universities or institutions. One of them might undergo the conventional teaching, the others might have a new intervention, such as an addition of a technology or a flipped classroom, and then they're tested afterwards. But there's less ability to control for variables. I thank you very much. I hope that this helps to enlighten things a little bit, and I'd welcome any questions or comments if there's any at the moment. So I'm just going to pause and we'll see if there are any questions or comments. And there will always be the option to ask at the end or to contact either of us as well. So if there are no questions, I'm going to hand over to my colleague, Paul Cronin.
So thank you very much. In this section of the webinar, I'm going to talk about some of the tools that exist to help with appraising medical education research studies. This is a little bit about myself. I am an associate professor at the University of Michigan. I'm also a cardiothoracic radiologist as well, just like Aine Kelly. With regard to my disclosures, obviously I have to disclose the AUR Research and Education Venture Fund grant, and I'd like also to thank the AUR for funding this and for this series of webinars. I too am an editor for the Evidence-Based Emergency Imaging book in the series of evidence-based imaging. So what I want to start off by doing is talking a little bit about the Equator Network. When I give lectures, I sometimes talk about this, and my experience is that many people have not heard of the Equator Network, and I really want people to be aware of this resource because it's actually a great resource. The Equator Network, Equator stands for Enhancing the Quality and Transparency of Health Research. And it has a number of resources. It has resources for researchers to help them with research methodology, and then reporting guidelines to help them report the research that they've done. It also has resources for reviewers and editors of journals to help them appraise literature as well. If you haven't been on the Equator Network, if you use a search engine and put in Equator Network, you'll come to their homepage, and this is what their homepage looks like. If you then go to Library, and if you click on Search for Reporting Guidelines, it'll give you the list of reporting guidelines that are available. And there's also this drop-down menu here, which breaks it down by study design, ranging from things like randomized controlled trials and experimental research to diagnostic test accuracy studies, and then to qualitative research, which would include medical education research. And then it gives you a list of the reporting guidelines that are available. You can also do this for appraisal tools as well. Now, it must be said that for qualitative research or medical education research, there are no specific appraisal tools available on the Equator Network. So there are a couple of options. One option is there is a review guideline that has been published by Bordage et al., and I'll get to that in a second. Or the other option is to actually use reporting guidelines and tools to actually appraise a piece of literature that has already been published. Now, these reporting guidelines aren't specifically designed for appraisal purposes, but people often do that with the idea that if you go through a piece of reported research, and if you go through the kind of the various points, and the authors and the people who've performed the research can hit all these points or most of these points, then the research is pretty well reported and probably has been pretty well done. And obviously, if there is less of these points hit, well, then maybe it hasn't been so well reported and maybe it hasn't been so well performed. So we start off by talking about Bordage et al., who have proposed a set of excellent review guidelines. So these guidelines go through a medical education research article, literally starting with the title, to see if the title is appropriate. So does the title of the research give you an idea, and accurately give you an idea of the research that has been performed? Next, you move on to the abstract to see if there is a structured abstract, and if that abstract matches the text. So the information that's presented in the abstract, is that the same as the information that's presented in the rest of the body of the article in the methods section or in the results section? The other thing to think about, of course, is the suitability of the journal reader. So if this is medical education research, is it being published in a journal in which the readership are people interested in medical educational research? Moving on next, then you review or appraise the introduction section. Obviously, you want a literature review, which should be comprehensive, and it should be up to date. It should obviously tell you what is has been done in the literature and how this piece of research complements what's already known in the literature and fills a knowledge gap. There should be an appropriate conceptual framework, there should be an appropriate background, and obviously there should be a medical education research question that is well articulated and an important topic. The research question should be clear and well articulated, and it should be relevant and important. And in the same way that clinical research should ask a clinically relevant question, medical education research should ask a relevant educational question. Moving on to the study design should be appropriate to answer the question. So you should be doing a methodology that can answer the question that's being asked. Next, you move on to the study outcome, and this should be relevant and important. With regard to assessment of the methods, you should assess or appraise for the internal validity of the study, the integrity of the study, how the authors tried to minimize bias, the external validity or generalizability of the study. The measurement instrument that was used should have appropriate scales, cutoffs, and thresholds. And obviously the statistical analysis should be appropriate. It should be able to answer the question. It should be appropriate for the methodology used. It should be able to give the information that you want, and there should be a balance of descriptive and inferential material. Moving on to the discussion, this new piece of research should be compared and contrasted to prior studies to describe how it adds to the literature. Conclusions should be justified by the data that has been presented. And if the study has limitations, these should be discussed. And of course, sources of funding should also be disclosed to make sure that there are no conflicts of interest. So this is an excellent framework for appraising a medical education research article, and are not very different from other appraisal guidelines for other areas in research, again, such as randomized control trials or diagnostic test accuracy studies. So it's following very similar principles. So as I said, one option is to use Bordage's outline of how to appraise medical education research. The other option is to take some of the reporting instruments or tools that are available on the Equator Network and use these to dissect a piece of research that has already been performed and kind of use it kind of unofficially as an appraisal tool. With regards to qualitative or medical education research, there is a tool that exists. It's called SRQR, and that stands for the Standards for Reporting Qualitative Research, and this is a synthesis of recommendations. And the way that these tools work is that there's usually a list of kind of bullet points that the author checks to make sure that they have done this as they're writing their research up under a group of specific topics, and they usually tend to work through the paper in the same way that Bordage's appraisal list does, so often starting off, for instance, with the title and abstract. So as we can see here, the first point has to do with the title, the second one has to do with the abstract. Next, you move into the introduction, so you discuss the problem formulation. You might want to appraise the purpose of or the research question. Next, you move on to methods, look at the qualitative approach and research paradigm used, researcher characteristics, things like sampling strategy, data collection, use of units in the study, data processing, data analysis, etc. The next section will cover results and findings. So to go through the synthesis and interpretation of the results, and then you move on to the discussion, again, talking about issues of how this research adds to the overall volume of literature, what are the limitations, and then other issues such as conflicts of interest and funding. With specific regard to research that involves interviews and focus groups, there is a reporting tool called CORREC. And COREC stands for Consolidated Criteria for Reporting Qualitative Research. And this, as I said, is a checklist specifically for research involving interviews and focus groups. This is a 32-point checklist that is broken up into 3 domains. The first domain looks at the research team, so they look at, for instance, the personal characteristics of the research team and the relationship with participants. The second domain looks at study design, so the theoretical framework, participant selection, the setting, data collection, and then the third domain looks at analysis and findings, so the data analysis and the reporting of the findings themselves. Specific then to survey research, there are reporting guidelines. There are 3 reporting guidelines. The first one is the good practice and the conduct and reporting of survey research. The second one is a reporting guideline called CHERIES, and then the third is a guide for the design and conduct of self-administered surveys to clinicians. So if we look at the first one, the good practice and the conduct and reporting of survey research, this is a 10-point checklist, though number 6 has several sub-points. It is used for the reporting of survey research. And the hope when this reporting guideline was produced was to assist in the production of high-quality survey work. And this is the 10 points here, as you can see. Heading 6 has a number of sub-points. But again, the sections work through the introduction. So for instance, the first 3 points are related to the introduction. Points 4 to 7 are related to the method section, and then you have the results and discussion. CHERIES stands for the Checklist for Reporting Results of Internet e-Surveys. This is a reporting guideline specific for web-based surveys. It's a 30-point checklist, and one of its functions is to better understand the sample self-selection and if there's a possible difference from a representative sample. This is the first half of that reporting guideline. Again, the subsections would include points around design, IRB, the development and pre-testing of the survey instrument itself, the recruitment process, survey administration, the response rate, preventing multiple entries from the same individual, and then the actual analysis of the data itself. The third reporting guideline is a guide for the design and conduct of self-administered surveys of clinicians. This is a 30-point checklist as well. The checklist outlines the reporting of the study design, the development, testing, and administration of valid questionnaires, and then how the authors try to minimize bias. This can be used in the design and conduct of both postal and electronic surveys of clinicians. As I said, this is a 30-point reporting instrument. The subsections would include points related to the abstract, the introduction section, methods, results, and discussion. Now, earlier on, Dr. Kelly said that in literature there can be primary literature. The other thing that we can have is secondary literature, which is an evidence synthesis of primary literature, with an example being things like systematic reviews and meta-analyses. People can perform systematic reviews and meta-analyses also of medical education literature. And if you were reading a systematic review and or meta-analysis of medical education literature, there is a reporting guideline that again could be used to help appraise that type of evidence synthesis. It's called NTREC, and this stands for Enhancing Transparency and Reporting the Synthesis of Qualitative Research. This is a 21-point reporting tool and goes through the various areas, including the aim of the evidence synthesis, the synthesis methodology, the approach to searching, the inclusion criteria for the primary literature included in the evidence synthesis, data sources, the electronic search strategy, study screening methods, study characteristics, study selection results, the rationale for the appraisal, appraisal items, the appraisal process and the appraisal results, and then also data extraction, what software was used, the number of reviewers, and how they were involved in the coding and analysis of the included primary literature in the review, study comparison, the derivation of themes and quotations, and then the actual results of the evidence synthesis, of the synthesis output. So in summary, I hope from this section you are now aware that the equation network exists, and it's a very useful resource both for people performing medical education research amongst other forms of research, and for people also potentially reviewing this. As I said, there isn't an official appraisal tool in existence, so Bordage has very well outlined a nice review of the criteria for medical education research manuscript appraisal. Another option is to use reporting guidelines or reporting tools to help you appraise literature that has already been published. With regard to qualitative research in general, SRQR can be used. With regards to research involving interviews and focus groups, COREC is a reporting guideline that could be used. With regards to survey research, there's the good practices for conduct and reporting surveys, CHERIES, and the guide for the design and conduct of self-administered surveys of clinicians. And then if you're getting into evidence synthesis of medical education research, NTREC is a reporting guideline. I'd like to thank you very much for your attention. And at this point, if you have any questions or comments, we're happy to take them.
If there aren't any questions or comments at this point, I think we will wrap up, and hope that you will revisit the webinar and the other webinars on the series. And thank you again for your time and attention from myself and from Dr. Cronin as well. And thank you again to the AUR for sponsoring this initiative, and we much appreciate them. Thank you. Bye-bye.